Brain teaser number 1. So which of the following sentences is false? HEV is a lone bystander in extrahepatic organ involvement. Causal association is not proven. Number 1. HEV is excreted in semen, but sexually transmitted diseases are not reported. Number 2. Number 3. HEV may cause mild to severe acute pancreatitis. Deaths have been reported. Number 3. IgM, anti-HEV, and HEV RNA should be investigated in all cases of Guillain-Barré syndrome. So option which is false? Option A is false. How many? Option A is false. Okay. For B, it's okay. So give any answer. I request you to give any answer. Okay. This may be मिश्रा जी आप ही बता दीजिए. Which is false among them? D is false. Okay, so यहीं पे रहने देते हैं इसको और आगे इन्वेस्टिगेट. So answer is clear. How? Let us go ahead. See. Brain teaser number 2. A 35-year-old gentleman with history of renal transplant 2 months ago underwent routine blood checkup. His hemogram, KFT, lipids, sugar, other parameters were within normal limits. LFT showed bilirubin 1.2 milligram, AST 132, ALT 148, ALP 190. He was on prednisolone 20 milligram OD, tacrolimus 3.5 milligram BD, mycophenolate minoxidil 300 milligram TDS. What should be the next line of investigation? AST 2 बार लिख दिया सर एक ALT सर. आई एम सो सॉरी सर. मान लीजिए एक ALT. अच्छा एक कोई भी एक ALT मान लीजिए, एक AST मान लीजिए. आप दोनों ये हाइपोथेटिकल केस है, बट I am ensuring you in the coming future more and more like this cases you are going to see. So routine viral marker, NAT for viral hepatitis in serum, review drugs are all perfectly all right. So at least for this I think a little bit. Actually this is a very uncommon topic, and chronic hepatitis E, Dr. Surinder has a little bit touched the topic, but I think this is usually not discussed a topic. Relatively uncommon to you are all. Whoever has said all is all right. So this is the outline of my topic. I will be covering this topic under this following heading. Epidemiology has been covered by Rakesh Agarwal sir in quite a detail. 20 million, according to the WHO 2015 fact sheet, 20 million HEV infection annually, 3.5 million symptomatic cases, 60,000 deaths all over the world. That is huge number. 2015. Now in 2023, it would have gone up. HEV is causing more than 50% of all acute viral hepatitis cases, and it is now proven that it is causally associated with the extrahepatic manifestation a lot. Now recent concepts within what we have seen within last 2 decades, it may progress to chronicity and very rapidly go to cirrhosis. Specifically, as pointed out by Dr. Surinder, in solid organ transplant, immunosuppressed HIV cancers. First of all, we are going to discuss about extrahepatic manifestations of hepatitis B. So what is extrahepatic manifestation? Usually hepatitis E causes infection of the liver, involvement of the liver. So involvement of any organ beyond liver is extrahepatic involvement. Hepatitis E may involve almost whole body, but the documented cases are in brain, kidney, pancreas, blood cells, joint. HEV has been documented in placenta, breast milk, urine, and semen, but STD has not been documented. So point number 1 of the MCQ. Among all these, neurological manifestations are most important because these have called dreaded complications. Extrahepatic manifestations are associated either in the form of prodrome or in whatever form in up to 90 to 95% of acute HEV and 5 to 11% of chronic HEV also. And causal association has been proved by well-designed studies. In some, asymptomatic lone bystander has been also reported. And what is the pathophysiology of hepatitis E? Why it causes extrahepatic manifestations? The hypothesis has been given or even proven sometimes that it causes tissue tropism. Hepatitis E virus has been detected in various tissues like cerebrospinal fluid, in pancreatic tissues, in other, wherever disease has caused, the people have detected it. Second mechanism is molecular mimicry. So many of the proteins of the hepatitis E mimic with the proteins of the body, and they cause immunological damage to that organ, and that results in the extrahepatic manifestation. So this diagram is showing basically some common. If not treatable, then don't worry. I have discussed in detail. So the largest number is neurological and involving nervous system, both brain, spinal cord, peripheral, pancreas, thyroid, heart, blood cells, kidney, joints. So almost whole body is involved by the hepatitis B. So these are some common phenotypes and some dreaded, very dangerous phenotypes: Guillain-Barré syndrome, neurological amyotrophy, encephalitis, and myelitis. And very well designed studies, case control studies, cohort studies, and case reports have proven that this may cause definite Guillain-Barré syndrome, neurological amyotrophy, and encephalitis. So we are all familiar with the Guillain-Barré syndrome. It causes flaccid paraparesis or even sometimes quadriparesis. 5 to 11% of cases have been clearly documented that they are caused by the hepatitis C. Neurological amyotrophy. When I reviewed, I first time came this term because I had not reviewed the MBBS or MD for neurological amyotrophy. Amyotrophic lateral sclerosis we all have read, so I correlated with that. So when I went into the detail, I found that it involves the bilateral brachial plexus and it causes various degree of neurological weakness in both upper limbs and shoulder pain. So the series which was described originally was by Dalton et al. So they gave a triad of bilateral shoulder pain, variable degree of neurological weakness, and deranged epilepsy. And they said that if all the triad are found, almost 100% that case is associated with the hepatitis C virus. Next is encephalitis and myelitis. As with other encephalitis and myelitis, hepatitis E associated myelitis and encephalitis is associated with very poor prognosis. And causal association has been documented by detecting the HEV in CSF and IgM, production of IgM anti-HEV in the intrathecal tissues. 2 deaths have been documented in the case series and case reports. So I think neurological manifestations are clear. Now we are going next to the retinal manifestation. I will finish in time, boss, Dr. Suren. So pathological phenotypes: membranous proliferative glomerulonephritis, cryoglobulinemia, nephrotic syndrome. At least 4 or 5 case series and well-designed cohort studies have been reported on this manifestation. And once again, causal association has been proven. Because as the hepatitis C virus RNA level goes down in the serum, the disease manifestations are gone. And one more thing is to talk about how to diagnose these cases and how to treat. Basically, MPGN, cryoglobulinemia, and nephrotic syndrome are diagnosed as usual. We do workup, urine routine microscopy, Clinical features, renal biopsy, and treatment. Most of the cases have either resolved by spontaneously or by since the chronic hepatitis E is present in solid organ transplantation or immunosuppression, or sometimes these are seen asymptomatic in immunocompetent persons also. So either they get resolved spontaneously or switching down the immunosuppression, or in some cases, in 3 cases I found, by giving to ribavirin. So diagnosis and treatment. Hematological. Most of the mostly case reports have been found out detecting anemia, thrombocytopenia, and monoclonal paraproteinemia. So not very large series, cohort or case series. So definite causal association is not proven in hematological manifestation. Acute pancreatitis is a rare complication. In 2015, a case series was published involving 13 case reports, 4 case series, and 55 cases. All were from Asia, and or they had history to the travel to that area. Mean age was 28 years, and male to female ratio was 18:1. So male predominance was there. Mean interval between the onset of jaundice and acute pancreatitis pain was around 10 days, and at least 82% cases were mild to moderately severe, and 10%, 18% were severe. 2 deaths were documented. So option number 3. Deaths have been documented in cases of acute pancreatitis related to hepatitis B. Now we are switching over to chronic hepatitis E. So chronic hepatitis E has been defined. Do I need to clear anything in extrahepatic manifestation? Although many other joints are have been documented, but clear-cut large series or causal association has been proven in only these, and all other diseases asymptomatic bystander, lone bystander in case series or case reports have been documented. So do I need to explain anything in extrahepatic manifestation, or switch over to chronic? So chronic hepatitis E is defined as persistence of hepatitis E iron, hepatitis E RNA for more than 12 weeks, means 3 months. So as it's been explained by Rakesh Agrawal sir, hepatitis E is a virus of genus Hepiviridae, and Hepiviridae has at least 7 species, A, B, C, D, E, F, so on. Among them, hepatitis orthohepivirus A nowadays has been expanded up to 8 genotypes. 4 initial 4, 1, 2, 3, 4 have been documented in humans. Rest others have been documented in animals. So now zoonosis, that's the concept of zoonosis. The orthohepivirus C is a pointer. Pointer is this. So orthohepivirus C basically causes infection in the rat, but due to zoonosis, this may cause infection in the humans also. So, and among these genotype 3, 4, and 7, HEV of orthohepivirus A have been associated with the chronic hepatitis. Only one case of genotype 1 was documented to have chronic hepatitis E, which traveled from Asia to Europe and was on immunosuppressive medications that developed chronic hepatitis E. So one case of chronic hepatitis E in genotype 1 has been also documented. But most of the cases are genotype 3, 4, 7, and one case of rat hepatitis E. Very clearly shown by Sir, the epidemiology. Genotype 3 and 4 are mostly found in the European countries, and these have been associated with the chronic hepatitis E also. Genotype 1 mostly in India and the southeastern Asia region. Genotype 4 in China and Hong Kong all. So the genotype 4 chronic hepatitis E cases were documented in China. Let us see a little bit of review in subgroup of patients how chronic hepatitis E evolved. So epidemiology in immunocompromised patients. So the first case of chronic hepatitis E was detected in 2008 in Europe in post-transplant patients, which he was on immunosuppression, and reducing the dose of immunosuppression did not evolve. Then ribavirin was given, and that led to the resolution of the virus. Gradually, then later on, several case series, well-designed cohort and case-controlled studies, which showed that hepatitis E can become chronic in patients in solid organ transplantation in about 60%. In one study in which 14 cases underwent solid organ transplant, 8 out of them went into the chronic hepatitis C. In autoimmune disease, a review describes 60 cases. Among 67 cases were documented to have chronic hepatitis C on various immunosuppressive medications. In cancer, leukemia, 17 out of 50 cases. In HIV, one case was diagnosed in 2008 after that solid organ transplant in Europe. And later on, 3 more cases have been documented in hepatitis C. Fortunately, after that, even a larger series have not documented chronic hepatitis in HIV. In 2022, 2 cases of chronic hepatitis E were documented in COVID due to the use of immunosuppressive medication like tocilizumab, and one more immunosuppressant was used in Europe, and that patient was developed chronic hepatitis C. So, what are the underlying mechanism of the development of chronicity? Basically, hepatitis E virus is cleared by the immune system. So, whenever there is dysfunction in the immune response, innate immune system, humoral immune system, due to any either acquired by the immunosuppressive medications or HIV, or due to any reason, primary immunodeficiency, that may cause the development of chronic hepatitis C. And it is the severity of immunosuppression and type of mechanism of the drugs used which causes immunosuppression, because not all drugs cause immunosuppression. The most important culprit agents are tacrolimus, everolimus, and rituximab. There are abnormalities in the inflammatory response also, abnormal macrophage, inflammasome reaction, a different concept evolving. Viral factors, genotype 3 and 4 more commonly associated, tropism for the extrahepatic tissues, zoonotic potential, quasi-nature. Quasi-nature is a concept. Hepatitis C mutates, not mutates, but it replicates. There are generation of subtypes. Immunity against one type develops, another type does not develop. So persistence. So modes of HEV transmission, mostly zoonotic, blood transmission, and other possible in China, waterborne, shellfish, fresh fruits, and vegetables have also been documented. As one case which was developed after solid organ transplantation, there was history of eating of shellfish in that. Most of the cases which were detected in Europe has history of zoonotic transmission. So laboratory diagnosis. Very good coverage by Dr. Katia. Is this? Okay, left. How to diagnose viral hepatitis? So anti-HEV antibodies are usually not useful for the diagnosis of chronic hepatitis C because due to immunosuppression they are not expressed. Nucleic acid testing are reliable both in the blood and stool, and this is the usual sequence of events how the serological markers and clinical features develop after acute hepatitis. HEV RNA in serum up to 1.5 months, in stool up to 2 months, but beyond 2 months HEV RNA is not detected. So persistence of HEV RNA more than 3 months is supposed to be chronic hepatitis C. The case report, case series has seen that chronic hepatitis E may vary from asymptomatic enzyme elevation to frank acute hepatitis to development of chronic hepatitis showing fibrosis, inflammation, and very rapid evolution into the cirrhosis, developing portal hypertension and even decompensation also. Extrahepatic as with the acute we have seen. So how to treat chronic hepatitis E? So first step is reduction. Mostly it is seen in the immunosuppression. So first is reduce the immunosuppression dose. Watch for 3 months. Not cleared, give 3-month course of ribavirin. If negative, well, happy. If relapse after cessation of ribavirin for 3 months, 6 months, and if persist, then in immunotransplant, liver transplant cases, interferon, but not in other transplant, because only in liver cases pegylated interferon can be given. In other transplanted cases, immunosuppression interferes with the pegylated interferon. And if no response or non-response to ribavirin, here also we can use pegylated interferon only in cases of liver transplant. So take home message: many extrahepatic manifestations are possibly related to HEV. Initially, it was thought that it only causes acute hepatitis E, but now proven it may cause chronic in immunosuppressed. In near future, more and more, sir is going to start transplant here. Our KGMU has started, but still many knowledge gaps remain. Why one strain causes, another strain does not cause. Geographical distribution, many a lot. So I think this is over. And any question, I'm ready. I will try to